Porter Awards. It's an organisation which celebrates NHS staff's work. And when I read, Graham, the commendation from Mark and Richard, honestly, I was almost moved to tears. I'm just going to share that with colleagues because I think it's wonderful. So Graham wrote us an email, Richard and Mark, and he said, we have two porters who stood out in terms of outstanding service, Richard and Mark. They took an end-of-life patient to the chapel garden during a very busy time last autumn. The sun had just begun to warm the day, and the patient, who was with his wife, identified that they'd like some fresh air. So Richard and Mark took the patient and his wife to the chapel gardens. The patient and his wife were overheard reminiscing about their favourite holiday destinations and their favourite flavour of ice cream. It appeared to be a very personal and relaxing moment for them. After about 15 minutes, the patient began to tire, so he was taken back to the ward. Richard and Mark then went to the Ravelo's restaurant, sourced the patient and his wife's favourite flavour of ice cream, and were prepared to pay for it themselves. When they took it to the ward, the patient and his wife were moved to tears because of the thoughtfulness of the two porters. We've just had the result of the National Award to show that Mark and Richard were recognised for their compassion and awarded certificates for second place. Now, this morning, Richard and Mark, we were talking about the importance of kindness and civility and compassion throughout the George Eliot as leadership values. And boy, oh boy, guys, you know, in what I've just read and what you do in your daily lives, you demonstrate leadership values, the values we want to stand for as an organisation. So it's with real heartfelt thanks that I want to thank the two of you on behalf of the board. I wish I was able there to present the certificate with you, but we'll sort of hand it, thank you, to you through the ether. So my assistant, my kindly assistant, will now hand you copies of the certificate. But as you kindly do that, I just again want to say thank you so much on behalf of the board. But in particular, thank you on behalf of the patients and their families for the work you do day in, day out. You're magnificent. Round of applause, board, please. So that can go pride of place on the wall at home. Show your loved ones, because you should be very, very proud, because we're proud of you.
Cheers, thank you.
Thank you very much.
Thanks very much.
You're very welcome to join us for the rest of the board, but I'll understand if you've got better things to do with your day.
Thank you.
Okay, look forward to catching up.
Russell. We've got work to do.
Thanks very much.
Thank you.
Thank you.
Okay. So we'll now move on to the normal business. Can I ask anyone who's got their digital hand up to take it down, please? So we have apologies from Catherine Free and Rupin. As I said, thank you very much for joining us today. Greatly appreciated. And we've got apologies from Glynis Washington. Have we got any new declarations of interest? Please raise a digital hand if we do. Okie dokie. So we'll then move on. We've got quite a busy agenda today, guys. And at the end of the agenda, we've got an animation which we want to share with you. So I'm going to try and keep the pace going. So we'll be moving at a fair pace of knots. So the minutes of the meeting held on the 2nd of March, was everyone happy with the accuracy of those minutes? If you weren't, could you please raise a digital hand? Okay, great, thank you. So we'll move on then to the action points arising. We're on page 19. The first two, which are with Dowgett and Hack, don't come back until the 1st of June. So we'll cover those off in due course. We then had Stephen to brief me on ophthalmology long waits, which Stephen kindly did outside of the meeting. So thank you for that, Stephen. The deep dive into cancer performance be brought back to the board on the 6th of April. That's included in the integrated performance dashboard, so we'll cover that off a bit later. Then the restoration, recovery, and I always forget the third R, there should be four. Report on priorities, that's coming back. We've got it on the 6th of April, but I think we're now saying the 4th of May, aren't we, Hank?
Yes, that's right, Jim.
Okay, thank you. Then we've got the Jenny to inform Rebecca outside the meeting on what the trust is doing to address wider determinants of health. We'll pick that up partly a bit later, but I understand that's been shared, Rebecca. Thank you, Jenny. Then the IRR closed down report to be brought back on the 4th of May. So we'll cover that off later on in the year at the next board. A full business case to address current gap in maternity workforce. That's going to come back next May after presentation to the Trust Management Board later on this month. Thank you, Dajit. Had a really good presentation for members of the public to be aware from a father talking about our maternity services and how we can do a much better job at supporting dads. Some really great work being done under Claire, our Associate Director of Maternity Services, in that whole realm. Some really sort of quite pathfinding work supporting dads through the whole journey to birth and afterwards. COVID virtual ward evaluation report to be brought back to a future board meeting. That's on next month as well. And Gertie to bring a report on staff wellbeing. Had a big discussion on that this morning, as well as a good presentation at the recent Foundation Group 3 board meeting. Glenn, you raised your hand?
Yeah, it's just to come in on the next point, the Star Board report. The decision's been taken not to publish that report. It did go through to the West Midlands Leadership Group. The Star Board will continue to meet, though, because it was due to finish now. We've made recommendations to the regional group on the way that the financial framework should work, the way that provider collaboratives work, lead providers for integrated care, and all of which that has been adopted. Further work on provider collaboratives is something I'll now be involved in, and I'll bring that back in as we move over the course of the year. Okay,
thank you, Glenn. So that was the next point arising. Then we had the issue of the safeguarding children doctor role. That's been now appointed substantively, Daljit, so thank you for that update. And then we had the new requirements, potential changes to current FPPT arrangements to be brought back to a future board. And Stephen, that's been updated in the fit and proper personal annual declarations report to the Public Trust Board. So thank you for that. Are there any matters arising that I've missed? Please raise a digital hand. Colleagues, therefore, happy to move on to Glenn's report. Glenn, over to you.
Thank you, Russell. So just pull out some highlights. Quite a long report, so I won't read it all out. And firstly, the NHS budget has been created in 2 halves this year, with the second half yet to be finalised. The first half is obviously dealing with the ongoing COVID pandemic, but also starting to address elective recovery. You see reference there to some additional funding of £1 billion that was identified to aid with elective recovery. An elective incentive scheme that will sit at system level has been outlined, and that we'll no doubt talk about that a lot over the next few months as we look at how we recover our services. And I'll come back to that indeed later when I talk about theatres. Planning guidance was published very late this year. It came out just a couple of weeks ago and set out a very much expected framework for that first half of the year as we deal with the pandemic and we deal with particularly vaccination and we prepare for next winter. I think that the key thing for me, though, was in those 4 bullet points there where we talk about the 4 core purposes of integrated care systems, which will now start to accelerate the implementation of across the NHS. That very last one, helping the NHS to support broader social and economic development, has been a late addition to that list. It's good to see it. It's already been accommodated in the objectives that we agreed at our previous board meeting in terms of George Eliot being an anchor institution locally. So we will push forward on a number of those initiatives. One of the key things about the planning guidance, though, is staff well-being. We talked about that this morning and indeed at previous board meetings. It'd be really important for us as we pace ourselves with elective recovery that we manage the well-being of our staff. And then it also references urgent and emergency care and the new measures that we will start to look at, and we'll start to bring those into board meetings soon. Discussions are ongoing about system capital allocations, which will be slightly constraining for the coming year. It looks like we may have agreed a settlement in Coventry and Warwickshire over the course of today, and we'll bring that back probably next time to update the board on the implications of that. The thing I particularly enjoyed last month was the 3 boards meeting, where all 3 trusts provided some feedback on some best practice. And it was particularly great to see the George Eliot A&E team talking about how we've transformed A&E. And indeed, we'll be pushing still our NHSI colleagues and CQC colleagues for that to be recognised in their assessment of us as an organisation, because we've significantly improved performance and recruitment. Then into the detail of some of the work that's going on within the organisation. The theatre recovery and restoration programme is really important. You can see the 4 phases that are identified there, including the 2 new modular theatres that will be with us over the summer. As a consequence of that, I'm confident that George Eliot will be able to deliver those milestones set out in the elective incentivisation scheme, but we'll need to ensure that the system meets them overall in order to access some of that additional national funding. There's then a long list of developments from our community teams that very much feel part of the organisation, even though they're run by our partner organisation, SWIFT, but they're very much an integrated offering with some of the telehealth solutions that are listed there, the work that's been going on with care homes, with virtual ward rounds, all of which has helped to reduce bed occupancy, shorten length of stay, and develop services that maintain patients in the place they call home, which is their care home in many cases. Advanced clinical practitioners also being developed there, and admission avoidance work with West Midlands Ambulance Service. Then I refer to the staff survey, which we spent some time looking at in workshop this morning. And that's also in a separate report on the agenda today, but I really wanted to highlight the significant progress that we've seen there, particularly in some of the assessments of our middle managers by our workforce, which is really positive to see, and also being highlighted in the Health Service Journal is as one of the top 10 most improved trusts regarding discrimination as well for our staff. And then some updates from Women's and Children's Directorate, including the way that we're managing the waiting list, the way that the gynecology routine waiting list has been managed, the way our sexual health service has been modernised. And then finally, I finish with the on a high with the High Sheriff Awards. I think we referred already to last month. We had some of our domestic team visit the board and talk about the work they've done during COVID. They were recognised by the High Sheriff, as was Elizabeth Ward, which is our main respiratory ward, which very much took the brunt of the COVID activity for the organisation. So great to see them recognised also. I joined a brief ceremony on the High Sheriff's last day in office last week to do another virtual handing out of those certificates. That's all I wanted to highlight. To take questions.
Thank you very much, Glenn. Clearly an awful lot going on. And I guess the other thing just to mention to members of the public is the board are acutely aware of those patients and their families who have been waiting for their treatment if they're on an elective list because of COVID. We are doing everything in our power to be able to, as a system, ensure that you are seen as quickly as possible. Any questions or perspectives to Glenn? Simon?
Thanks, Russell, and thanks, Glenn. A really comprehensive and thorough update, giving a great overview. You mentioned anchor institutions in your report, and just thinking about the workshop this morning and some of the themes that are going to be very important to us as we go forward, would it be possible to think about having a board workshop on the specifics of anchor institutions and the possibilities and what we might learn from elsewhere in terms of people who've done that well? I would just find that very, very helpful.
With Chairman's permission, that sounds like a really good idea.
No, great, thank you, Simon. And any other questions or perspectives to Glenn? Okay, great. Thank you, Glenn, and thank you for your leadership. We'll therefore move on to the Restore, Recover and Reset programme update.
Thank you, Tim. Thank you, Chairman. The programme has had 82 projects across 7 work streams, so it's a very broad piece of work which goes beyond the narrow Restore, Recover and Reset, recognising that Restore, Recover and Reset isn't just about elective activity, it's everything else that goes on in the hospital as well that makes it all come together. And the key that we built it on is our improvement approach, which was in train well before anyway, and the key part of that, our improvement approach, is about improvements being led by the services, by those people who are closest to treating our patients and understand the services the best. So the coordination cell provides the project management support and a resource for capturing and sharing that good practice and learning and helping to make some of the interconnections and doing managing some of the bureaucracy behind the scenes, so the staff who are running these projects and get on with making the improvements. So that's the approach that we've taken, building on what we'd already done previously, and it links in with shared decision making as well as part of our overall improvement approach. As you know, over the last few months, COVID has meant that from a recovering elective activity perspective, we haven't been able to do that, but there has been a lot of work going on in terms of focusing on staff wellbeing, driving vaccinations, managing the actual impact of COVID, and making sure that we continue to maintain safe delivery capacity, as well as planning for next year. And as part of planning for next year, as you've already heard, we've restarted elective activity. The operational clinical colleagues have developed some really good plans at specialty level to recover activity over the next few months, and those are built on some really detailed demand and capacity models that we've now got, which means we're in a better place than we've been previously in terms of understanding exactly what capacity we've got. And it's also worth noting that we're taking a very similar approach to recovery this time around as we did to phase 3, recognising actually it's a bigger challenge from a staff wellbeing perspective and giving time to staff to recover as well. But in terms of our approach to planning and understanding of our capacity means I think we're in a very good place, as Glenn said, to be able to at least hit the national recovery trajectories, if not exceed those. And it's worth noting that back in September, October time, we were the only one of the providers within our system that actually exceeded the national trajectory. So I think we're well placed to recover well again. Alongside this, it's really important that we use that additional capacity, the wards and the theatres, really productively. So we've got a theatres improvement programme and an outpatients improvement programme that is being led by those particular departments to make sure that we are productive and that we are able to see and treat patients as quickly as possible. Just the final point I was going to make was around the transition. So we're transitioning the Restore, Recovery, Reset programme to more business as usual, as part of improvement being the way we do business in the organisation and the way we run the organisation. So as part of that, we will ensure that we continue to improve with working closely with our partners, involving patients and service users, and getting better at measuring those improvements and reporting those improvements through the improvement board and through to Trust Board here. We're also rolling out QSA training to our partners as well, and making it opening up access to our partners so that we're all working in the same way. also working with Warwickshire North Place in terms of having an improvement programme that crosses the whole of Place, recognising that actually we can't do this on our own. This is about how we work together better, and also finally capturing the lessons we've learnt so far, making sure that those are shared widely and that we build improvement work into the service development plans that we are working on, that the directors are working on. So at directorate level and specialty level, we will have plans that incorporate improvement. So improvement is part of normal day-to-day business rather than something that stands in isolation. So I'll leave it there and take any questions on that.
Very comprehensive, thank you, Hack, and sort of indicative to members of the public and to citizens that we serve just how much work is going on to get our services not just up and running again, but ensuring that we're more productive and able to cope with more volume as we go forwards. Julie?
Thanks, Chair. Thanks, Hack. It's a really good report, and as Russell said, such a huge amount of work being done there and coordinated by the coordination cell. I just wanted to ask a question, because one of the things that we've said that we're going to be monitoring through Audit Committee is the use of resources, and I just wanted to check how these relate to each other so that we're not duplicating reporting, because that would just not be efficient. So if we could just understand the relationship.
So we had a discussion at Audit Committee about this, and part of the follow-up work that we're doing on that is exactly what you suggested, is making sure that what we're doing links in directly with use of resources. So use of resources isn't seen as a separate piece of work. It will be embedded as part of those service development plans that I've just spoken about within the directorates, including the corporate directorates as well. So we will have, it'll be part of all the planning and all the improvement work rather than something that's separate. What we will do though is pull out the reporting for use of resources separately against the 8 or 9 specific recommendations, so Audit Committee can see clearly that we're making progress on those. But you'll see through the IPR at board and through the work that we do through the Finance and Performance Executive as well, various metrics that will get reported that will show the improvement that we are making in relation to use of resources. So yeah, it'll be absolutely embedded in the work that we're doing and not done separately.
Thanks, Hack. Thanks, Julie. And finally, Rebecca.
Thanks, Chair. Thank you, Hack. A comprehensive and very useful report. Just interested in regards to the transition arrangements, and particularly how operational managers are going to be supported in that transition process to make sure that the trajectory we've set so well is sustained. Can you say a little bit more about that for assurance, please?
At the moment, a lot of this is being run operationally anyway. It's run by those services directly. So from that perspective, the transition from an operational clinical service perspective, they're not going to notice a huge amount of transition. The transition is really at the back end about how we describe and organise things from a project management perspective, right? But because as I said earlier on, a lot of these improvements are being run directly by the services, and the work that the directorates are doing at the moment in terms of developing the service development plans, these changes are all embedded in there. So like the theatres improvement programme, the outpatient improvement programme are an integral part of the clinical support services directorate service development plan. So they won't notice a huge amount of change in terms of the way they're working, because we've been working on this transition for a while, and it is led by the services anyway in terms of the improvements.
Excellent, thank you.
Thanks, Hack. Such a good answer that Stephen Coleman came on, raised a digital hand to answer the question, but was so impressed by your answer, he put his hand down. Thank you, Hack. We'll now move on. Thank you very much. We'll move on then, and we've discussed them a number of times, the annual objectives for 2021 and end of year progress assessment. Glenn?
Yeah,
Jenny?
Jenny will do the detail on this, but just to say, despite the obvious focus of the last year on the pandemic, it's really encouraging to see the amount of progress on the objectives that we set prior to the start of the year, with lots of green on the objectives and a bit of amber but no red. And Jenny's included a number of improvement stories behind those headlines. So, and Jenny, do you want to add any more detail to that?
I think you probably covered it really. I think the story is that there's been a such a lot of delivery done despite the pandemic, but alongside the objectives that we set out in terms of the specific actions, we've also done more because there's been things that people have done from the ground upwards and from within services that have been about them taking forward the essence of the objectives and delivering them, as well as the activity that we'd planned to do. So in this report, you've got what we set out to do, and then you've got the added additional work that the operational teams and the wider corporate teams have supported in terms of actions they've done that are in line with the objectives. So I think that says it all. Really, thank you.
So questions and perspectives to Jenny or Glenn? As David Olchingham says, it's great to see the improvement stories in the appendices. It really brings things to life and is a testimony to the way we're invigorating the culture of George Eliot to embolden people to improve and feel the opportunity to take forward their own improvement objectives. Colleagues, happy to move on? Okay, so then on to the Warwickshire North Place update. Jenny, what would you like to put out here?
Yes, thank you. So I'll take the report as read. I think, as you can see, there's quite a lot of activity that's going on across Warwickshire North Place, and very much integrated and linked into the work with George Eliot colleagues and Swift colleagues, as well as other partners. I guess the key highlight would be to acknowledge that the clinical strategy that we've been working on was endorsed by Place partners and continues to be linked together with the work that we're doing now around the business cycle to include the developments within partner plans and links across. The other thing to pull out would be the mental health workshop, because obviously that's a key priority area, particularly on the back of COVID, and the workshop was really a real focus of a number of partners coming together to look at how we would want to make sure that we focus on our mental health recovery within our Place programme. Also, I'd like to just point out, because we've talked about health inequalities, and again, that's a real feature going forward within the Warwickshire North Place plan, and we've got 3 key objectives that we're taking forward within our health inequalities programme for as part of our Place programme. I'm happy to take any other questions, but those would be the 3 things that I'd just pull out really in terms of demonstrating, I think, that as a place that we're really focused on some of the key areas that are also part of the business planning and the operating plans that have just come out, and we're in line with those to take them forward.
Thank you, Jenny. Questions and perspectives. Simone?
Thank you. Jenny, you talk about the Place metrics and measures of success, and I was just wondering whether they might also include workforce metrics.
Yes, so in terms of the metrics, we're building those up, and the intention is that we would have metrics that would sort of demonstrate the sort of work towards integration. And I think one of the things is definitely around workforce and collaboratively how we're working through. So we're looking at a range of things within that. We've still got some work to do in terms of really sort of getting the focus so that we're not just looking at sort of health metrics, but we're looking at sort of health and social care metrics. And also we're wanting to reflect the sort of healthy communities, healthy people sort of agenda within our work within Warwickshire North Place plan, but workforce is obviously a key metric, absolutely.
I think it's really important from an assurance point of view that we join up the strategic workforce agenda along with the health agenda, and that we understand supply and demand from a workforce perspective as well as from a health perspective.
Absolutely. Glenn, is there something you wanted to add to that?
Yeah, I would certainly agree with that as priority, and the opportunity to co-locate some of our staff as well with partner organisations will be key. I just wanted to flag a little bit of a concern linked to what I said earlier about access to capital, because there are 1 or 2 projects that would help us to co-locate staff and improve our efficiency, but we could well be limited in access to capital over the next 12 months because it's not readily available across the system.
Thank you, Glenn. And then finally, Rebecca.
Thanks, Chair. Thanks, Jenny. When I think back to where we were a year ago and we look at the footprint as demonstrated in this report, it just shows how much progress we've made at Place. The question I've got is in regards to the fact that there are so many initiatives happening at Place, and I wondered if it might be useful to produce some kind of benefits map which would very simply illustrate how these deliverables link to benefits and link to our priorities. So just a very clear diagrammatic small chart of how these link together. I don't know if that would be useful.
Rebecca, can I ask you maybe to have a chat with Jenny outside the meeting to bring that alive? I think that would be very helpful. Thank you for the suggestion, Rebecca. Colleagues, happy to move on? Okay, thank you, Jenny. So we move on then to the Safe Nursing and Midwifery Staffing Report. Dowd.
Yeah, thank you very much, Chairman. So the data for this report refers to February, and the report highlights there have been some challenges, but the staffing levels, the safety has been mitigated during these times. I do want to highlight, however, that the position is much improved on previous months, and you can see from the report that our sickness levels due to COVID and nurse staffing have improved quite a bit. So provide assurance that the tight governance remains in place so that we can quickly respond to any areas of need highlighted and mitigate any risks. So referred earlier on to the board workshop this morning regarding the work that we're doing around retention and recruitment for nursing. I think our key area of priority at the moment is the focus on the growing number of registered nurse vacancies that we've got. It is on the risk register at the moment and it's currently rated at a 16, but we do recognise that in addition to recruitment, it's really important that we have a wider workforce improvement plan to enable to grow and develop and retain our own nursing staff. And again, you know, a good discussion at board this morning, which gives a highlight of some of the programmes that are in place that will start to improve the situation over the coming months and years. I think it's important to recognise that, you know, nationally there is a view that the experience of COVID-19 and some of our nursing workforce, you know, living through that is likely to have a impact. And therefore, you know, the well-being and the experience of our staffing group is going to be really important. In terms of areas of high vacancies, again, as highlighted at board this morning, we are doing some bespoke recruitment events in those areas. But I do want to end with a positive, which isn't within the report, but just to note that our vacancies in our maternity unit are very low. And in fact, less than one whole-time equivalent. And I think that's quite remarkable when you compare the issues around midwifery vacancies nationally and indeed locally. So I think in future reports, we'll be bringing more information around midwifery staffing as well.
Thank you, Dowd. And it was great, as you mentioned, this morning we had a presentation from Delia talking about the education work we're doing in terms of nurse apprenticeships and everything. And I'd just say to members of the public who are considering their career options, maybe they've gone to university, they're looking at different ways of thinking of their life journey. A career in the NHS as a nurse or as a doctor, as a porter, whatever position you want to take, the NHS is a great place to be employed. And we would welcome you with open arms at the George Eliot. Questions and perspectives to Dowd. Okie dokie, it's just started to snow where I am. I hope it's better for members of the public wherever they are, but it's getting, the weather's somewhat interesting at the moment. And in terms of other things that are interesting, we had some really positive staff survey results from last year, which we discussed comprehensively this morning, Gertie. And so Gertie, what would you like to pull out of this report for us?
Thank you, Russell, and appreciate that the report itself covers most of what I want to pick up, so I'll just be quite brief. I think it's worth reminding members of the public that the 2020 staff survey was undertaken between October and December in last year, and that's in the context of a global pandemic and significant pressure on our staff. It's a very good key resource in assessing our colleague engagement and how staff feel about coming into work and the organisation they work for. And it's really positive to note that many, if not most, of the areas we'd identified for focus from the 2019 survey have actually improved, particularly two statistically significant improvements in health and wellbeing and immediate manager skills. What's most important for me, and I will just pull it out very quickly, is that our colleagues have reported improvements in three key questions reflecting their view of the organisation and the care we provide, and that's that they are able to deliver the care they aspire to, that they would recommend the trust as a place to work, and that most importantly that they would recommend the trust as a place to receive treatment. You can see I've included some comments within the report about staff group and directorate analysis, and I'll finish up with just commenting on the areas of future focus, which do pick up some of the areas that we had identified last year, including equality, diversity and inclusion, and health and wellbeing, and bullying and harassment, and all of the areas where we have seen slightly less progress will be picked up through those key work streams. And we'll also look to finalise the Excel behavioural framework, which we've worked with colleagues in the latter part of last year to develop, but haven't been able to move forward because of the second wave of COVID. Along with that, over the coming year, we'll see the development of the people experience strategy, which will continue with the development of the culture of kindness, joy and inclusion in the organisation. I don't intend to bring any more to life this afternoon, Chair, as it's in the report, but I'm happy to take questions.
Thank you very much, Gertie. Any questions or perspectives to Gertie? I know colleagues did spend an hour on this morning. Just a couple of things then from me. One was to reiterate in public what I said this morning. I think these were quite remarkable set of results in the context of the year we had last year, and illustrates the great work that under David's leadership we're doing at the front line to engage more with our staff. So thank you to all of the executive team for the leadership you're providing and the culture of an environment you're encouraging for us to grow around civility, around kindness, around compassion, which is really great. So thank you. The second thing is on the diversity agenda. Maybe Gertie, you and I can take it up another point. I really want to make sure we're including neurodiversity in our thinking about what we mean by diversity. That people who might be dyslexic or on the Asperger's scale or something like that, that we don't forget them. Some of the most able and effective and competent colleagues I've ever worked with in my working life have been on either dyslexic or on the Asperger's scale. So I really want to make sure that's included in our thinking about diversity. Colleagues, happy to move on? Thank you. So we'll then move on to the CQC progress and preparedness update. Dajit?
Yeah, thank you very much, Chairman. So the report was written at a time when the virtual meetings regarding the collating the evidence against the actions were on hold, and those have recommenced this month, so we'll be able to start triangulating some of that evidence. The current picture is that we've got only one action, which is a must-do, which is AMBER, and that's around medical mandatory training. And we recognise that COVID is likely to have had an impact on that. However, I do want to emphasise that in terms of infection control training, we have really reinforced that, encouraged that throughout the pandemic, given it's really important that infection control standards remain high. Along with the must do there, we have got some should do actions which are AMBER, and there's going to be a strengthened refocus on addressing these. In fact, the executives will be discussing each of their areas this week in a meeting to look at what else we need to do to quickly close these actions. Happy to take any questions.
Thank you, Dajit. Questions and perspectives to Dajit? Glenn?
It's probably just to note the attendance of the CQC at the three boards meeting that I referred to earlier, where I think Daljit pleaded with them to return to inspect us as soon as they possibly could, and obviously they heard at that session the really good progress that we've made, particularly around the emergency department and the recruitment there. But hopefully they will come back and assess us, or we'll find a way of virtually assessing us so that we can move forward, because that their rating of us still sits there alongside our organisational performance, and things have gone on. I mean, that action tracker really sets it out in terms of the way that we've responded to their previous issue.
I shall carry on pleading.
Thank you. Don't sound too desperate though, Dodgy. Don't sound too desperate, but it's good to invite them. Colleagues, happy to move on to the integrated performance report. David, over to you.
Thanks, Russell. So I'll give some headlines from the report, and then if anybody's got any questions, we can pick those up, and colleagues will join in the Q&A session where that's appropriate. So in the order that the reports are presented in the document, starting with mortality, you can see that we still have some concerns about our HSMR being outside the expected range, which it has been for the last 3 months. Having said that, in the preceding months it was within range, and we think there's probably some COVID impact in there because HMSR was not designed to deal with the pandemic. And Catherine is leading a specific piece of work and has in her objectives for this coming year an objective which is very much about helping us to understand what the impact of COVID on our mortality rates across the hospital has been. In the meantime, every COVID-related death is being reviewed by the COVID mortality review group, which includes one of our medical examiners, and Ruben, who's in the room representing Catherine today, is very close to that work. Moving on to falls, the rate of falls per 1,000 bed days is less than the internal threshold that we've set, and also the national standard. There were 10 avoidable falls during the reporting period, and the team have made sure that there's been reviews of each of those cases, and learning has taken place against each of the events which resulted in those falls. We've heard already about the infection prevention control processes that we have in place, particularly around managing COVID infections across the hospital, but also a range of other things. One case of C. diff to report in this month's report. Dealing with COVID has been a significant challenge for the whole world of infection prevention control, from our specialists who are experts in the field right through to our domestic team. And Glenn made reference to the fact that the domestic services team received a High Sheriff's Award for all of the work that they've done through the COVID pandemic, which reflects their contribution to keeping the hospital safe and infection under control. Moving on to emergency care. So an improved position against previous months in February, and still in terms of relative performance regionally doing really well, and appearing in the top quartile of performance across the ED picture for the region. No ambulance delays above 60 minutes in February, which is a key sort of measure of our ability to offload patients, assess them and move them through the hospital. And that's really something that stands out across the region. You've heard previously about the letters of congratulation that we've received from the ambulance service, but that really is incredible progress, and it's a whole hospital kind of result. So although the measure is down in A&E at the front door alongside the ambulance service, if the hospital isn't flowing, it's impossible to meet that standard. And so important to see it as recognition of the way the whole hospital is operating. So really good to see us continuing to improve and perform against that standard. In terms of diagnostics, after a challenging period in February, we achieved the 6-week diagnostic standard with 99% of patients who were waiting for a diagnostic procedure seen in less than 6 weeks. Moving on to cancer, and picking up just from the action log that you mentioned right at the beginning, the cancer position again remains something that the executive team are scrutinising closely. So we have 5 patients who are waiting more than 104 days for treatment. Those patients are waiting for care on specialist pathways or have chosen to wait, and there is a case management plan in place for each of those patients, carefully overseen by our cancer lead. In terms of greater than 62 days to treatment, shared breaches with colleagues, particularly at UHCW, continue to be a challenge around their ability to see these patients in the context of everything else that's going on. But again, there's a case management plan for pretty much every patient who is waiting for care on those pathways, and we work very closely with UHCW to make the best of the capacity that's available. In terms of elective care and the RTT position, so this is planned care, patients on 18-week pathways. The size of the waiting list in pretty much all specialties have grown considerably over the course of the COVID pandemic, and we improved somewhat as we came out of wave 1. We've deteriorated somewhat as we've come through waves 2 and wave 3, depending on how you describe those things. Probably the most important indicator in terms of this is the number of patients waiting 52 weeks or more for treatment. And if you go back to February 2020, that was pretty much down to zero. Reported today, we have 1,326 patients who are waiting longer than a year for treatment. Now, that's not unique to the George Eliot Hospital. That's a position that you'd see reflected in every hospital across the land. But obviously, that's something that we want to deal with as quickly as we possibly can. And so our recovery efforts are going to be intensely focused on that group of patients. We are pretty much back to normal in terms of turning the capacity taps back on at the hospital. This is our first full week of operating back at pretty much the normal operational level that you would expect to see in the hospital, given the context of COVID. And of course, we expect to build that capacity even further going forward. And Glenn mentioned in his report, we're pretty confident that we'll meet the greater than 70% 1920 baseline target and exceed the 85% baseline at the hospital. We've got the new theatres that will come online. I'll say more about that in just a moment. But we expect to be able to meet and exceed the targets that the centre have set. But we've got to bear in mind that these are system targets, and therefore the risk is that we perform other bits of the system are not able to, and there's a risk associated with that in terms of financial flows. And the issue with the new theatres is that we were advised last week that the construction company that are responsible for building the new theatres are experiencing slight delays with materials associated with Brexit, and where we'd hoped that the theatres would be available in early June to us, we now think that it will be July before we've got access to the theatres to make them operational. And that's despite the best efforts of those involved in managing that project. So the risks there are around system levels of performance, our ability to get the theatres that we've started to build online because of delays to the supply of materials coming out of Europe, and obviously also the workforce and staffing risk, which we've talked about in other contexts. So moving on to workforce, we continue to work hard, as we've heard, to recruit into the Band 5 registered nurse vacancies that we have across the organisation, and indeed as a board we spent considerable time on that in this morning's session. We've talked about the staff survey as a separate item, and so I won't spend any time on that. You'd be pleased to hear that absence rates across the hospital are coming down as we come out of the last wave of COVID, and also that we've continued to do incredibly well in terms of vaccination delivery, and excellent work there led by Gertie well into delivery of second doses. And I visited our vaccine clinic and met Jane, the vaccine centre manager, last week, and what a great job they're doing up there. A fantastic team of people contributing to the vaccine programme. So I think I'll stop there, conscious of the time, and if anybody's got any questions, we'll be happy to deal with them as a team.
Thank you very much, David. Very comprehensive, and it's interesting when people blame Brexit for everything. Not you, but supplies. Glenn?
Yeah, it was really comprehensive, and it's good to see the position we've got ourselves in. I just wanted to I don't know if this is a question or just an observation. In order to achieve those elective recovery targets, we will also need to manage urgent care carefully, particularly as we go into this winter. David, what's your view on there's a narrative I'm hearing from elsewhere that we need to keep some sites red and some sites green, sites that do elective and sites that do emergency. It sounds like a very London solution. Do you think that's something we should be thinking about here?
So I'm not convinced that that's the right model for Coventry and Warwickshire, and I think you know, the London position is different based on a large number of hospitals in a very small geographical footprint. I think from conversations I've had with colleagues, something like half the geography or the geographical size of Herefordshire, with 18 hospitals plumbed into it in reasonably good, well, very good transport infrastructure. I think that's a different scenario to the scenario that we face here, and I think the work that we've done to establish the Captain Sir Tom Moore surgical unit and create a green area of the hospital that's absolutely distinct from the areas where we're looking after patients on urgent and emergency care pathways, creates enough protection for us to be able to operate both pathways on the same site. So I'm not convinced that's the right approach.
Completely agree.
No, so do I. I think it's an absolute nonsense for the avoidance of doubt in places like Coventry and Warwickshire to be thinking about green and red sites. Those who are suggesting it, frankly, need to get real about just the practicalities of running in London, areas outside of London. Any other questions or perspectives to David? It's probably just worthwhile for members of the public explaining why 80% is, if you like, a challenging benchmark in terms of recovery post-COVID. And it is, correct me if I'm wrong, David, it is because of all of the protocols we now have to have in place to minimise, from an infection prevention and control perspective, the risk of infection and COVID coming back. We put in place a series of protocols, and the consequence of those protocols is if effectively we lose at least 20% of our previous capacity volume. So just getting back to an 80% number is actually quite demanding in itself. So that's just some contextualisation for members of the public. Colleagues, happy to move on to the finance report. Hack.
Thank you. I'll take the finance report and the capital report together to help with time. They are closely interlinked anyway. So in terms of the income and expenditure position, we've continued to improve because of the impact of COVID. We've been seeing lower levels of elective patients than we originally assumed. We've also had additional income from the respiratory network and the STP reserve, as well as some income for non-tariff drugs. And sickness levels improved during February, and we also had recruitment as well, which reduced some of our temporary staffing costs. And you can see the COVID costs came down consequently. We're still forecasting a break-even position, and we're confident we will get there. There's a £1.5 million accrual that we need to make for annual leave. There'll be at least £1.5 million, so we're working through the exact number, but that'll be funded nationally. So they'll fund up to 5 days for all staff going forward. So that £1.5 million is based on 5 days for clinical staff only. Focus going forward is on improving the underlying run rate. So that's about reducing our COVID costs further, improve productivity, as I've mentioned already, urgent and emergency care pathways and managing flow, continued recruitment and reduction in temporary staffing costs, reviewing our SLA, some of our outsourced contracts, procurement savings as part of our shared service work across the group, and looking at prescribing across Warwickshire North Place. So those are the key areas we're focusing on in terms of looking at improving our underlying run rate. From a cash position, as I mentioned last month, we've still got high cash balances at £46.5 million, but I expect that to come down by around £10 million at the end, by the end of March, to about, well, end of March is gone, around about £35 million, because we're not going to receive advance payments, and that is still more than sufficient cash for us to be able to continue to pay suppliers as quickly as we possibly can. In terms of capital expenditure, we're forecasting spend of £17.1 million. That is a huge investment that we've been able to make in George Eliot Hospital. It's the biggest investment the trust has seen in a very long time. And I think one of the things that I just wanted to recognise the work of Kirsty Webb, our head of estates, and the estates team, and actually in delivering some really big projects to time and within budget. It's a huge effort, and we didn't put in additional resource into that team, so they've done a brilliant job really of delivering such a massive capital programme. And it's not just the theatres and the wards is a big achievement, but it's all the other work that they've had to do alongside managing around running the complexity of running a hospital in a pandemic as well. So that's a really great piece of work to deliver that scale of capital programme under the current circumstances. I think under any circumstances would have been a huge achievement. So as I said, we've delivered 2 wards, the 2 theatres are on site, a few more months to get those, get the internal work done and get those commissioned and fitted out. There is a bit of a risk in terms of overspend on that, potentially up to £500,000. That's related to a significant increase in commodity prices, steel and copper mainly, and you'll have heard lots in the news about some supply chain issues and the likes of Liberty Steel operating at lower capacity than normal. We're working through very closely with the suppliers, and we're confident we will manage to mitigate most of that risk, but at the moment I couldn't say that we can mitigate all of it, but we're working very, very hard to mitigate that risk. In terms of COVID spend, we've spent £2.3 million, but we only received funding of £700,000. But the STP as a whole is underspent on its capital programme, so that'll get covered as part of the overall STP capital programme. Because we've had to go ahead and do the right thing for our patients and spend the money ahead of getting confirmation of funding. The funding has also been confirmed quite late within the year, so we've had to get on and do some of these things at risk, but within the at a controlled level of risk really, but within the STP we've got it covered. So I think we have demonstrated good controls despite all the late approvals on the capital programme, and managed to deliver a significant investment to schedule within budgets. I'll stop there and take any questions.
Thank you very much, Hack. Any questions or perspectives to Hack on the finance report? Hack, can you just explain something to me? We've got the capital page, which shows up until the end of February we spent 9.5, but we're saying that by the end of March we'll have spent 17.1. Spending 8 million in a month sounds pretty fruity. I assume the 17.1 is a correct number, though.
It's a correct number. We will spend that. I'm confident we will do it. Actually, we have done it, so I'm confident we have done it. Half of that is on the ward. Just over 4 million is on the theatres. There was still some spend left on the ward as well, and there's some significant pieces of equipment as well. So I'm confident that we've got it covered. It is a huge amount to spend in 1 month, but we had some really good plans in place to be able to manage that and make sure we've delivered that.
Okay, and I think just again as a point of reference, because I know capital is going to be a real issue in the year ahead, and I know our STP will almost certainly be capital constrained. It is absolutely appropriate that those organisations in any ICS which have a PFI do not receive the same allocation of capital as those organisations that don't have a PFI. Those who have a PFI, their capital is maintained through revenue, the payment to the PFI. Those like us that don't have a PFI, frankly, need capital spend to keep our assets in a good condition. So just to make that absolutely clear, and I'm sure that some colleagues actually forget the common sense of what I've just said, but I'm confident, Hack, you'll be pointing out to them in a straightforward but polite manner. Colleagues, happy to move on to the quarter 4 capital report, which goes back to the 17.1 million.
So, sorry, Jim, I've covered both reports in one go.
Thank you. And Neil, you've raised your hand. Apologies, I didn't see it earlier.
Yeah, thank you, Chair. Very quick point. Huck, there were some challenges in terms of timelines for getting board approval. I wonder whether this is the right place for you to suggest the option for getting the approval of the submissions?
So we'll come on to the planning paper in the confidential.
Okay, that's
board
fine.
paper.
That's fine.
Okay, thank you, Anil. And any other points, or colleagues happy to move on? Okie dokie, thank you, Hack. So the first is the annual review of, so we've got the approval of governance documents section. The first is the annual review of standing orders, standing financial instructions, and scheme of delegation. Hack, Sarah.
So if I just start off and then Sarah can chip in. I was going to say a lot really, because we haven't made any significant changes, and that's largely because we'll do a more comprehensive review as part of the group shared services piece of work, and about looking at aligning standing orders and SFIs across the group. So there's very few changes here at the moment, just to reflect our latest governance structures.
Okay, thank you very much, Hax. Sarah, anything you want to add?
Just that Audit Committee did review this document at their meeting on the 23rd of March, and their comments have been incorporated into this version, so it's for the board's approval.
Okay, thank you very much. Any question from our colleagues? Everyone happy to approve? Please raise a digital hand if you're not happy to approve. Okay, duly approved. Thank you, Sarah. Thank you, Hack. Then we've got the annual review of directors' register of interest. Is there anything you want to add to this, Sarah?
No, thanks, Russell. It's just for formal noting and information.
Okay. Are all directors happy that their relevant bits are accurate? Please raise a digital hand if you're not. And therefore, on that basis, everyone happy to receive and note? Thank you. And then we've got the fit and proper persons annual declaration. Sarah?
Thank you. So I think the report's self-explanatory. I have included an update in there about the recommendations following the CART review, which was an ongoing action for me for some time. So happy to take any questions. It's for receiving and noting. Thank you.
Thank you very much. Any questions from or perspectives from colleagues? Please raise the digital hand. Okay, thank you, sir, for pulling all of that together. So we're then on to the Board Assurance Framework Q4 report, the high and extreme risks only. David and Sarah?
Yes, so Sarah's going to take us through this, Russell.
Thank you. So again, happy to take this report as read, just to highlight that review of this is the Q4 position. So the execs will undertake a review to do a year-end position, which will either close down these risks or transfer them over to the BAFA 21-22. So happy to take any questions.
Thank you very much, Sarah. And I'm conscious of how much work goes on behind the scenes on these Board Assurance Framework summaries. Any questions or perspectives from colleagues? Okie dokie. So thank you for that. And then use of the trust seal. You're on a roll now, Sarah.
I am. So again, this report is for information, and there hasn't been the use of the seal since my last report in April 2020.
So that's easy to receive and note. Okie dokie. So colleagues happy to move on? And so we're then on to the annual review of board subcommittee terms of reference. Best back with you, Sarah.
Thank you. So each committee has reviewed its terms of reference, and the proposed amendments are shown for the board's consideration. But there's also a recommendation for the board to consider a proposal to change the name from the Nominations and Remuneration Committee to Appointments and Remuneration Committee, as it's felt that that's more reflective of the committee's remit.
Okay, thank you, Sarah. So everyone involved in the subcommittees have been involved in this process. So if we just take the terms of reference first, any questions on the terms of reference changes which are highlighted in red, please raise a digital hand. So on that basis, if you're not happy to approve the adjustments to the terms of reference, please raise a digital hand. Okay, on that basis, all terms of reference duly amended. And then the change of name, are any colleagues unhappy to change the name of the subcommittee to the Appointment and Remuneration Subcommittee? Please raise a digital hand if you are unhappy to approve that change. Okay, great. Thank you, Sarah. Duly approved.
Thank you.
You can now take a break. And we'll move on to the Audit Committee annual report and annual objectives for the year ahead. I've got Hack down on this. Maybe it means Julie.
Hack, I'm quite happy to take this if that's okay.
I think it probably should be you, really, shouldn't it, rather than me?
Yeah. So I'll take the report as read, and answer any questions. But this report sets out formally the purpose of the committee and how we've complied with our terms of reference. Chair, I'd like to take this opportunity to say a very big thank you to the members of the committee. We have lots of honest and open discussions and contributions at our audit committee, and that allows me to give the board assurance around the work of the committee and that we provide added value to the trust. The proposed objectives are set out in the report. I just wanted to add that as a group of audit chairs, we get together regularly within the group, and that we are going to be sharing learning between us, because there's an awful lot of information and learning that we can now gather and provide into the audit committees. That's all I was going to say, to accept questions.
Thank you, Julian. I think that process of being able to share with the other chairs of the audit committee across the foundation group is proving helpful to all of the chairs. So thank you for your leadership role in that. Any questions or perspectives to Julie on the Audit Committee annual report and annual objectives for the year ahead? Please raise a digital hand. I would just like to reinforce thanks to everyone involved. It's all of the non-execs who are involved in the board subcommittees undertake a substantial amount of work. So on behalf of the board and the citizens that we serve, I just want to thank everyone. And again, Julie, for your chairing of that committee. Thank you. We'll move on then to the Quality Assurance Committee updates and reports from the 22nd of February and the 29th of March. Simone and Rebecca in Glynis's absence.
Thanks, Russell. Just to affirm that the committee continues to focus on essential business presently due to pressures related to COVID. We did have fulsome discussions to inform reports at board today regarding the staff survey, maternity quality assurance, and also the quality oversight report. Key points to note that QAC particularly took assurance on are that whilst a number of clinical governance groups are stood down temporarily, those critical to patient safety have continued. That we noted that the backlog of incidents that remain open are increased due to staff capacity. However, we were assured that as governance groups are now being reinstated, that confidence will certainly be addressed. Clearly, workforce remains a challenge for us, particularly in some areas, but again, QAC remains cited on these aspects of our service, including mitigations being taken. QAC once again noted the positive work in relation to our volunteers that's undertaken within the trust, and we acknowledge that work. And then finally, QAC continued to monitor mixed-sex breaches, and were assured that these were appropriate to prioritise patient safety, none of which exceeded 24 hours. Thank you.
Thank you, Rebecca. So any questions to Rebecca in Glynis's absence? Okay, thank you again, Rebecca, and thank you for everyone involved in that subcommittee. We'll then move on to the Audit Committee report from the 23rd of March, which Anil kindly chaired. Anil, what would you like to pull out?
Thank you, Chair. I'll take the report as read, pull out a couple of the things. One is that we had discussion around the annual financial reports and all the works going on around the annual completion of our reports. So there are two aspects to that. One is in the report, I have quoted the opinion of internal audit perspective, which is positive unless something drastically changed in March. And from the external audit perspective, I think, Glenn, you mentioned it, Daljit mentioned it as well. We're still hampered by the out-of-date letter from NHSE regarding the significant improvements we have made to our A&E. And it was agreed at the audit committee that on behalf of the board, perhaps you or the chair can escalate the matter to NHSEI to get a revised letter recognizing all the wonderful work that has been done. So if I can escalate that to the board chair. And finally, there were two internal audit reports that were presented, one around ambulatory care unit and another one around governance reporting structure. And I'm pleased to say the outcomes in both of those audits were reported as positive. I'll take any questions anybody has, Chair.
Thank you very much, Anil. Glenn?
We'll let Hat mention first whether he's got anywhere with the escalation of that before I comment on what we do next.
I think that's exactly what I was going to do. Thank you, Glenn. Yeah, so we are expecting a revised letter towards the end of this month, but there are two issues for the board to consider. One is that most trusts, if not all trusts, are actually missing the performance targets. So on that basis, you could argue that every trust should be getting one of these letters, but that's not what's going to happen. So there's something about equity potentially around this, but I don't think we'll get anywhere with that, but it's something for the board to consider. It's only those trusts who've already got letters will get revised letters. So they're not going to issue letters to everybody for missing targets. The second point is a more important point, which is around a particular phrase that's used within the letter. And that phrase refers to a failure of governance, is the term that's used. What it's saying is that the fact that we missed some of these performance metrics, it demonstrates a failure of governance. And clearly it doesn't, because there's good reasons for some of those why the performance looks the way that it looks, and also we've done a lot of work to improve the performance. So the letter, as I understand it, will acknowledge the improvements we've made on performance. What's not clear at the moment is whether they are able to remove that phrase that refers to a failure of governance, but because they haven't been able to confirm yet whether that's a standard phrase that appears in all the letters or whether that is specific to us. The issue with that use of that phrase is that when external audit look at it, what they say is if your regulators are saying there is a failure of governance, then we have to take that into account, and that is a key factor that then might result in a qualification of the value for money audit opinion. So that's the key consideration here. So we would be looking for support from the board to write to NHSEI in relation to the use of that particular phrase in particular, and asking for that to be removed or justified.
Removed, I think. Glenn?
Yeah, I mean, it feels appropriate for me to get involved and have a conversation with the NHSI team, because the frustration here is that if they'd been worried about us, we would have had an inspection during this winter, which would have led them to be assured about us. The fact that they weren't worried about us means that we're stuck with an inspection that is now approaching 18 months old. That's not satisfactory to us. I understand why they've not been able to inspect, obviously, but they ought to be able to at least remove the failure of governance phrase, because they've had plenty of assurance from us, particularly bearing in mind one of the main issues was the recruitment of consultants, which is factually in a much better place than it was when that statement was given to us. So I will.
Can you keep me briefed?
Yeah.
Can you keep me briefed on that? Because I wholly reject that phrase, failure of governance. And so if you can keep me brief, that would be good. Thank you, Anil. Any other questions to Anil? So the Foundation Group Strategy Subcommittee report is the 22nd of March. Julie, is there anything you'd like to add to this?
No, Chair, I'll take it as read.
Okay, great. Thank you very much. And then the Quality Assurance Committee of the 22nd of February, we'll just note, unless there are any questions. And similarly, the Audit Committee of the 26th of January, we will just note, given that they've been previously approved. Okay, thank you very much. So I'll come on to any other business in a moment. Sarah, were there any questions from members of the public?
We did receive a question from a member of the public, which actually is a complaint, so it's not appropriate for us to discuss in the public domain. So the detail has been shared with Diagnostics, and it's been investigated under the trust complaint policy, subject to consent from the patient or next of kin.
Okay, thank you, Sarah. Diagnostics, can you keep me briefed on that, because it's clearly not appropriate for us to talk about individual patient details in a public forum. Yeah. But it is also important for us to make sure the due process is followed when a complaint's been received. So if you could just keep me briefed on that as appropriate, that would be good.
Yeah, I can confirm it's been investigated, and also we've dealt with any immediate issues as well.
Okay, thank you very much, Darjit. So I think we've got David on the line as a member of the public. I can't see, and John. Quickly, because we have got pretty long any other business. David, any questions from you?
None, thank you, Chair. Just as usual, my thanks to all the staff at the George Eliot for what is an unbelievably, remarkably brilliant job that they're doing. Thank you.
Thank you, David. I'll give you the fiver later. And John?
No, Mr. Chairman, what David said, thank you very much for all the good work you're doing. It is much appreciated by all. So thank you and the board very, very much. I know you will continue it. So many, many thanks. Thank you.
Thank you, John. So any other business before I come to Jenny? Okay, Daljit, you may not have seen it in the notes, John, but Daljit has said to John and David, we miss you. We miss seeing you physically. So looking forward to when we can get back to physical boards rather than digital boards. So we do have a piece of any other business regarding an animated video we've had made of the work we've done on the annual objectives. I'm conscious of bandwidth potentially on this, so it's probably worthwhile those, and I think particularly Glenn and I who are on video, turning our videos off. But Jenny, do you want to share the animated video with us?
Yes, I will do. So I'm just going to ask James to actually load it for us, and just to say that thank you to everybody that took part in providing information to go into the animation, and hopefully you'll see on the animation a range of different initiatives that people across the organisation in a number of teams have undertaken and shared as a celebration of some of the work that they've achieved. So hopefully if we can get the IT to work, we'll be able to display it to you. So I'll go off camera and ask James to load it for us.
Okay.
My name is Chris Bain and I am the Chief Executive of Healthwatch in Warwickshire. Healthwatch Warwickshire's main purpose is to ensure that the lived experiences of the patients and public of Warwickshire are used to inform and influence the decisions taken by those who commission and provide services in the county. So we'll do this by collating the views of people who live across the county and communicating them to those who have to make decisions. We have found very willing partners in this, in the George Eliot Hospital and in the North Warwickshire Place Executive on initiatives such as the clinical strategies on urgent and emergency care and on mental health. We very much look forward to working with both of those partners on new and exciting initiatives going forward in the future.
Hi, my name is Will Jones. I usually work in occupational health, and as part of my role, it involves vaccinating staff. I'm very happy to be able to utilise my skills to assist the vaccination team in giving the COVID vaccine, and it makes me proud to be involved in the National Vaccination Programme.
Hello, my name's Janet. I work in practice education, and I've been supporting in the vaccination. I have to say I found it a really friendly, supportive environment, and it's nice to meet the staff and the members of the public that are attending for their vaccinations. We get the chance to answer any queries and questions, which often allays any fears and anxieties around the vaccination process.
everyone. My name is Dr. Amir Yousafzai. I am the digital lead and emergency medicine consultant. I welcome you to the digital transformation of emergency department at George Eliot Hospital. I was a part of the second cohort of QSER course, and my project was to implement a digital pathway for electronic radiology requests from emergency department. I'm happy to share the news that we got this implemented within 2 weeks with 100% compliance. This was the first step towards a digital ED at George Eliot. This further led to similar mini projects successfully implemented in very quick time, like electronic pathology requests, like sending all the bloods requests electronically, e-prescriptions to outpatient pharmacy, referral pathways to ambulatory care or STEC, scanning our ED notes, and we are currently working on a couple of things like direct entry of patient observation onto the patient portal and electronic discharge summaries from emergency department. This has significantly improved the patient's safety, reduced errors. It has improved the patient's and staff satisfaction. It has also improved our digital maturity and organizational readiness for a bigger change in near future by having brand new state-of-the-art electronic patient records. We have worked together as a team and owned every single change we wanted to bring about. I want to thank QSER team, every member of my ED team, and the senior leadership for supporting me in this role. This is just a glimpse of what has happened recently. There is much more good stuff to come. I thank you all for watching this video.
Thank you, Jenny. That just by observation, I think would be really great to show potentially at the AGM. So we'll remember that. But in the meantime, thank you very much, members of the public and colleagues. I look forward to seeing you at the next board. Can I suggest to Board of Director colleagues that we take a 10-minute comfort break and get going again at 20 to 4. See you in about 9 minutes. Thank you. We do have separate dialing details for the next call.